Good afternoon, everyone. Thanks so much for joining our session today. I'm Taryn Barker. I'm a director of sexual and reproductive health and rights at the Children's Investment Fund Foundation, and I'm co-chairing this session with Siobhan Crowley, who leads HIV at the Global Fund. We're really excited to have you here today to talk about HIV self-testing and some of the differentiated service delivery lessons that we all learn from implementing the CIF and Global Fund self-testing matching fund in Grant Cycle 6. We're very excited that today it's really a panel with many of the governments who've been responsible for taking self-testing to scale in this matching fund program, who've had really amazing results and have tested out many different channels, building on the wonderful work that PSI and Unitaid started with the STAR program, who then were also providing a lot of the technical assistance to this program as well. So I'm delighted to kick us off by passing the microphone to Siobhan Crowley, who will tell you a little bit about the Global Fund program that has been implemented.
Okay, good afternoon, everyone, and thanks very much for joining us. We had a fun session about HIV self-testing and blood-based testing, and there were lots of questions from the audience, and we have some very, very wonderful panelists who've worked through the real problems of doing this in the real world. As you know, the Global Fund is a major supporter of HIV responses in low and middle income countries. About 50% of our funding is directed to HIV support. And within that, we support whatever in the national program is required or needed. And in many of the countries, we support HIV testing is a very important part of that, obviously, as is treatment, as is prevention. We had this particular push in the last cycle to really see countries try and understand their testing strategies and use the range of testing modalities that are available to us. And one of the vehicles we had to stimulate that was a matching fund for some of the countries to go a little bit further with the HIV self-testing. I'm sure you're all aware that it's been around for a while. We've been promoting differentiated service delivery for some time and using different models for delivering testing services, both in terms of facilitating prevention, finding our missing cases, and also allowing people to come back and retest and come back into care, have all been important modalities, and sort of figuring out how you're going to be reaching the people that are probably missing from your classic service delivery models. So these models, what we were hoping to hear from our countries is how they've used self-testing to expand their testing repertoire and explored some of the channels that they've been using, including virtual interventions. And each of the countries has taken slightly different routes to do this. I mean, some of it, as Karen alluded to, started from the Unitaid supported STAR project, but others were starting from, learning that they wanted to include it. And I think what we wanted to have an opportunity today is to hear from the countries what they've learned, what they would suggest to other countries that are looking at sort of scaling self-testing, and what we further work and further things we need to understand as self-testing comes of age. Just by way of background, we spend about 50% of, we supply about sort of 25% of the market for low and middle income countries, and the rest is domestic, and of course PEPFAR, who are supporting countries in their buying their test kits. In that we have about, in any year we have about 250 million spent on HIV tests, which is providing around roughly, because they've now come down to about $1, that number of tests. For the same amount of money we spend on malaria tests, we get about 820 million malaria tests. So there's definitely room for further price reductions. And in self-testing alone in this last cycle, we spent about 16.5 million on HIV self-test. Much of that was driven by the 4 countries in the matching fund. And two of those countries are here. We have representatives on the panel from Uganda, Jeffrey Tassi, and then from Nigeria, we have Imadada, who leads the HIV testing and prevention program. So I think we're going to be joined. I don't know if Alaris is in the room. we're expecting South Africa, the head of the HTS program, to also join us. So maybe they'll join us as we go along. And what we wanted to do, there's going to be no presentations whatsoever. We were going to try and put them on the spot a bit and explore some of the things that we thought were difficult or interesting about the programs. And then we were going to open the floor up to participants in the room to ask questions. So I'm going to hand over to Taryn. We're going to just ask a couple of questions so that countries get a chance to just give you a flavor of the models they were using. And then we have some very specific questions which we feel that have been kind of important for us to understand. So Taryn, I'll hand over to you for question number 1.
Thanks so much. Dr. Ima, my first question is for you. I'd love you first to tell us a little bit about what the different differentiated service delivery models have been that you've been implementing for self-testing in Nigeria, and then talk to us a little bit about the policy and governance challenges that you've had to overcome in implementing some of them.
Thank you very much. Yeah. So for HIV self-testing in Nigeria, we started the implementation was around 2020, 2021. And one of the things we did was to come up with policy documents, and we came up with operational guidelines for HIV self-testing. And HIV self-testing is one of the DSD models we are using. And one of the things we did in the guideline was to come up with different distribution channels and models for HIV self-testing with the targeted populations. And we also have, just like I said, different distribution channels, and we also have different approaches. We have the primary and the secondary approach, which we use for the distribution models. And we have facility-based, we have community-based, and we have the private sector. For the facility is more of secondary approach, secondary distribution. That's when I say primary and secondary, I mean primary, the test kits that a client is given or he purchases and takes. But for secondary, for your network, your children, your partner, that's the secondary. So for the facility-based model, we do more of secondary distribution. Initially, we had that issue with the facility-based distribution because along the line, we discovered that HIV self-testing was used as a first-line test to test, and there was a kind of abuse. So we had to come up with a recommendation that for facility-based, it should be more of secondary. For index testing, ART, ANC, where we have our partners of pregnant and breastfeeding women. But if you come to the facility for testing, we give you the conventional testing is being done, not HIV self-testing, but it can be used for secondary distribution. You can take it to your partner. That's for the facility model. Then for the community, we use both primary and secondary distribution. So it could be for yourself, it could be for your partner, it could be for your network. And we look at the OSS as part of it. We look at mobile outreaches, institutions, closed set, all those areas that has to do with community. So whereby we can either do primary or secondary distribution. So for the community model, we use both distribution approaches of primary and secondary, reaching out to more people in the community. While in the private sector, we do both primary distribution and secondary distribution. And when we talk about the private sector, we are talking about the community pharmacist, patent and proprietary medicine vendors, where you can go and buy your test kits and use or buy for your partner or whatsoever. And we are also talking about the private labs. We're talking about the private clinics. So this all comes under the private sector. And they also look at different population, because like the private sector, anybody can go in and buy and use, those who have the money to buy. Then for the community, at times there is free distribution, and thanks to donor partners who have distributed some test kits in time past, where it's being distributed even to the adolescent in the community. So they are being captured in the community, and they will do both the primary and secondary distribution. So the challenge we had was in the facility days, which was a strong point. And where the challenge, another challenge we had in the facility was that the providers, the health workers were now, they were conducting the test to the clients. The clients were not doing it, and they were doing it. So it was like an abuse, which we had to stop. That no, it's not that way. And we had to come up with some capacity building for the providers and all the those who are involved in testing, so that they know what the right thing to do, following the operational guidelines for HIV self-testing.
Thank you so much. I mean, it's fascinating to hear how in a very short period of time, you scaled up self-testing through so many different channels. A quick follow-up question. What is the age of access for self-testing in Nigeria? At what age can adolescents, for example, access a self-test?
Being HIV self-testing, being a testing that is being done even in the community, you find out that you see adolescents even at 15 who go and get test kits. So it's in the community. They can do that. So use the mic. Oh, sorry. Oh, sorry. So at the community level, you get adolescents of 15 who go to the facility, who go to the either the community or the pharmacy to get the test kits. The only issue you will have is if it's in the facility. If it's in the facility, you will be asked of your either your guardian or your parents, to give consent. But once it's out there, it's there.
That's great. Thank you so much. With the speed of the scale and integration into government programs, one of the big questions that we've heard a lot through this conference, but also elsewhere, is about how do you monitor and demonstrate that so many different channels are effective at reaching people. And Karen, you've worked across so many countries now doing this work. How should countries think about monitoring and tracking linkage and positivity in these big scale programs?
Very good question, and that came out also on most of the question from the panel this morning, from the audience. And I think that probably the most asked question, apart of how much does self-testing cost and how cost effective it is. That was the major questions that governments asked when we introduced self-testing in specific countries, in different countries. So I think I would like to say first a couple of things to this before I'm going and responding to your question. First, we have to understand that self-testing is not an alternative to conventional testing, but an additional tool, a screening tool actually for people that is accessible, that is convenient, and that reaches people who are shying away from the provider-delivered testing. Okay, so it's client-centered and addresses sort of the barriers that people have to access testing services. It is also out of the control of the provider. So if you're applying the monitoring systems for testing that we have with the typical cascade, linkage into care and access of testing services to this, it might not work, because this is the attractiveness of self-testing, that it is client-centered. So we have also to trust the clients with regards to linkage into care and treatment and prevention. Secondly, self-testing is screening tool. So it's the TO, okay? It's not a T1. So obviously for somebody who tests positive or reactive, as we say this, with an HIV self-test, needs to be referred or needs to take up confirmative testing by a provider, and then obviously going through the national algorithm to confirm the positivity of this test and then to access treatment services. Somebody who tests negative with an HIV self-test doesn't need to be having confirmative testing for HIV because the test is negative, and he can actually access with that self-test PrEP services, as you have seen in the simplified guidelines from WHO or the policy brief that came out, and that is already implemented in a couple of countries. You can now use a self-test to initiate PrEP, at least oral PrEP and the tapering ring, and also continuing monitoring of PrEP intake for effective use. So again, that is also an important aspect to consider. Linkage between testing and prevention services, between testing and treatment and prevention services that are provided at a community level is not new in terms of finding ways of how we establish these linkages. And HIV self-testing is not addressing that. Yeah, so we have to understand that self-testing has been provided as an additional tool, screening tool, but it does not answer necessarily the question in terms of how we improve linkages. But what we have with self-testing is a tool that is already self-motivated. So somebody who takes up a self-test has already the motivation, probably because he feels themselves at risk, or wants to access prevention services. He knows that self-testing or testing is an entry point. So the person who takes up a self-test is different to a person who gets offered a test at the public health care facility because he has already done a thought process. Yeah, self-testing is an entry point. So he's more motivated, likely more motivated, and has already information on his hand of how and where to access treatment services. He might already have in his head where he might want to access PrEP services or comes in for BMMC and uses self-testing as an entry point. So this is what I think we should be understanding. I think also we should be really distinguishing between referral and linkage tools, that we can provide to clients who take up self-testing and then monitoring and tracking of individuals for self-testing. And I will speak to both of them. So that the tracking and monitoring, typical cascade for self-testing is, people reached with messages for self-testing and taking self-test up, then people who use the test, people who based on the use of the test, what the test result is. And then obviously the next in terms of cascade would be the linkage and uptake of confirmative testing, and then the uptake of treatment. Yeah, and that's sort of the cascade for self-testing. And where self-testing is more in controlled setting, like in public sector healthcare facilities where we're using this as a screening tool, these indicators can be collected. But when we're distributing self-test kits at community level, or so non-assisted self-testing, like in pharmacies, where self-testing is now available in many countries, as you have heard, in Uganda, including Uganda, and also Nigeria. It is out of the control, obviously, of the providers. And what we had initially, implemented also through the STAR program, because we wanted to provide the evidence that self-testing leads to uptake of treatment, care, and services. We followed up with the clients directly to get their results, followed up whether they use the test. But obviously, this is not something that we can do at a wider scale. We don't have the resources. We cannot track each and every individual client, whether they have taken up testing or prevention services after self-testing. So this cascade monitoring is not required. But what I want to speak about first is sort of the linkage tools that have been put in place. So with assisted and unassisted self-testing, we have to equip at the point, because post-test counseling is not available for the client because he uses the test on his own. So in the messaging that we are providing also through our training of pharmacists, for example, or community-based distributors, is to provide the information to the clients that access the self-test, to give them information on where they can access treatment and care services. So it's not following up, but equip them with that information, handing out leaflets, handing out also potentially vouchers, so that they can, in case of positive result, access these services in healthcare facilities. We have also developed digital platforms that help clients through that process of self-testing, that actually signpost people also to outlets where they can access self-testing through an interactive process, there's either WhatsApp or or Facebook based, people can actually work with this digital counselor through the testing process using the self-test, either the oral fluid test or the blood-based test. And at the same time, people can also report back their results. They will be prompted and they can report into the system anonymously, and the information will be directly linked into DHIS2 of the nation system, and we can actually analyze this data. Obviously, this is all on a voluntary basis, so people can buy into this chatbot, get the information, get linked, get through the testing process, and then will be linked into care and treatment, getting the information as well as the chatbot. So these are some of the tools that facilitate linkage into care and treatment. We've also provided, I think Uganda is a very good example, hotlines that people can access, where a counselor, personal counselor, which is also, by the way, the option with a chatbot, where you can, at each step of this process, always also phone an individual counselor or a person to provide information if people have questions about where to access services, how to conduct the test. So we have hotlines as well that facilitate referral into care and treatment or prevention. Now, so these are, I think, the tools that we should equip people with that take up self-testing without tracking them. Now, let's look at the monitoring and tracking tools that we have as well. As I said initially, obviously, one of the options would be to track the clients when they receive the test, get the telephone number and following them up. This is some of the stuff that we used initially just to show the impact of self-testing on uptake of tests. And this cannot be done on a routine basis, as I said. But for some of the models that we're implementing in terms of self-testing, for example, secondary distribution through network distribution, social network distribution in amongst key populations or social networks, is that we have a person that distributes those self-test kits at community level to the people that receive them, and these community workers or peers can also directly follow up with the people that have received the self-test, because they have provided them with the information, and they will also be helping them into linking into care. Yeah, so this is one way. For secondary distribution at public sector healthcare facilities, for example, to reach partners of pregnant women or lactating women or people who access the health delivery system, maybe doing through index testing as well, index cases. The index case or the pregnant women can also follow up, obviously, with the partner on the test result, and can report at the next ENC clinic visit whether the person took up the test, what the test result was, or whether the person has been linked. And then we can follow up through those individuals as well for secondary distribution. Yeah, but I think just the emphasis is, it's more the emphasis on how we can establish this linkage, or empowering the people that take up self-testing to link into care and treatment and prevention. One of the other points would be that we are providing indeed services where people are accessing self-testing. So, example, pharmacies where people access self-test kits, they could also provide at the same spot confirmative testing. They can also provide PrEP. So these are sort of the pharmacy-led models. So bringing the services, the post-test support services, treatment, care, and prevention to the places where we're distributing the self-test, so that people can immediately link into these post-test services, is also another option of establishing linkage. Yeah, but I think we should really shy away from monitoring each step of the HIV self-testing cascade with this unassisted self-testing. And again, I think facilitating linkages and referrals is the answer to that. Thank you.
Thanks so much, Karen. And I think we all know who to turn to if a government or a program is looking at implementing self-testing or scaling it. We know who to go to for tools. Just quickly, I want to welcome Alarise from the South African Ministry to the panel. Glad to have you here. A quick follow-up question. Either Jeffrey or Emma, what data has been most important to you in terms of the self-testing cascade in your program management? If either of you would want to answer that.
Thank you very much. I think that the previous speakers have described everything that we do in Uganda. So for us, really, I just want to first make one statement that one thing we've done so well in Uganda is that we've understood our epidemic and we know our response. So we now know where the remaining 80% of the undiagnosed people are, who they are and where they are. We also know where the new infections are happening, where we have high incidence. And of course, I think like many countries now, it's shifting to the young people, AGYW. So precisely our self-testing program, I can say now that self-testing is at the heart of differentiated HIV testing. So our self-testing program, of course, is structured in such a way that you want to, of course, identify a few cases, but also you want to largely use this for prevention. So in our differentiation, one of the things that we had a challenge with actually was the young people. And so we had to do feasibility studies to really understand what it takes providing self-test kits to young people below the age of 18, because initially our policy was 18 and above. So we started this in adolescents, 15 to 17, for about 1 year in selected regions. And we found it feasible. There was no social harm like some people had thought. These young people will commit suicide and all that. So it was a barrier to reaching the young people. And as I speak now, the biggest chunk of HIV self-test kits have been allocated to AGY, adolescent girls and young women, and boys. But of course, the girls are the majority. So just wanted to first make that clear. So in terms of DSD for HIV self-testing, we are differentiating for populations, but also differentiating in terms of approaches and then the geographies. You want to know where do we have majority of the young people? What approaches works for them? What do they prefer? Yeah, like we know that the young people prefer peer. Key populations, also the peer approach works for them. So you want to look at the population, you want to look at the channels, but also you want to look at the best approach to reach the people. We have the men, for example, and recently we tried out a campaign for men, the border men, these guys who use motorcycles for taxi business, and it was very interesting because they don't have the time, so we had to go through the border stages, and you work with peers, trained peers among them, and distribute the kits, and it was very interesting. So one point I want to make is that we must go where the people are. We have to find the people. We have to find the people and go where they are. Facilities, secondary, we've done very well. But who else out there are we failing to reach? So we need to go where the people are if our differentiation is to work. So coming now to the question, the cascades for HIV self-testing. Again, at first we were very disappointed because you give out kits and then you really don't know what's happening to the majority of the people who are taking the kits, save for a few who probably test positive and then come for confirmatory testing. But even then, you've got, I think, also should not shy away from the fact that you've got to make some investment and do some follow up. But of course, also assuring that there are support systems and that people who are accessing self testing are not completely detached from the healthcare system. Yeah. Because if you have the peers, if you have the community volunteers, if you have the toll-free line like we have in Uganda, um, you know, those are some support systems. But also for people to feel that they are not completely so detached, that they are not on their own. Because at the end of the day, I've done a self-test, I have a negative result, positive result. Okay, what next? So I'm negative. So where do I get a condom? I'm negative. Where do I get PrEP? I'm negative. What else? Has my partner tested? So those support systems are also important, even as we differentiate. So what we've done, we developed simple tools like for the community distributors to make sure that as they distribute the kits, they take some record. Yeah. the peers can still follow up and find out if this person has any challenges. They prefer assisted, they prefer to do it on their own, and then record. The other interesting thing we've done is that we, under secondary distribution for fear of GBV, we designed the form, especially for ANC, antenatal women, or anyone taking to their partner. We designed the form, so we first do some screening. We ask you a few questions, about the partner to whom you are taking the kit, yeah, so that our intervention does not cause harm. So those simple tools pick some data that then feed into the national system, and we are able to report. So the most important thing in that cascade for us is, of course, to know who are tested positive, and then have they come for a confirmatory test. But again, it's not easy to attach first of all, every positive result to the kit that you distributed. So our tools are also open. The HTS register is first of all open, that when people come, if they did a self-test and they were reactive, it's then captured. So at national level, then you can aggregate that at the end of the month, and then try to make sense out of it. How many were distributed, how many results were returned positive, and then how many were confirmed using the national algorithm. So by and large, I think for the issue of self-testing cascades, we need to invest more in surveys, maybe after a year or after 2 years, do some kind of assessment, do some kind of survey, and ascertain exactly the impact of your work or your contribution. Otherwise, the routine data monitoring and reporting may not really be a very fair way of talking about, of discussing, the impact and what you're achieving. We'll be judging ourselves so harshly. So finally, for us in Uganda, we are actually optimizing. We've scaled up geography, population. So we are like, okay, now, what is it that we are not doing well? What is it that region X is not doing well? Region Y is not doing well? How are the commodities being managed? How is the supply chain? Who has a stock out and why? Who did they give the kits? So we are looking at all those processes to ensure that there is fidelity, to ensure that there is quality, and that self-testing is working for everyone. I think someone already talked about the private sector.
Thanks so much, Jeffrey. And it's great to hear about the people-centered approaches, going to people with demand creation, making sure that the systems for linkage are really about supporting them. The last question before we open up to the audience is for Alarise. And South Africa has one of the most mature self-testing programs. You've been operating at scale for many years. What does the future look like for self-testing in South Africa? Is it more private sector, new populations, new models? Where does the ministry want to take it?
Good afternoon, and apologies for being late. We were lost. So as you have indicated, self-testing has really had a huge impact in South Africa, reaching its first 95. Through the modality and the approach that we adopted, it really yielded quite a number of positive results. In the new, our new revised policy, we have expanded to a number of populations, population groups such as ages between 12 to 17. Self-testing is now available at facility level. We've also expanded to peer-to-peer groups, especially in our key population sectors. We're also looking at expanding to our private sectors, because the self-testing is available in our public health facilities, but we also want to see self-testing being available in our private sectors, our private GP sectors. So through our men's clinics that is available in our private sectors, we are currently supplying them with self-test which then gets reported to the Ministry of Health. We would also like to expand the program amongst our PrEP users for engagement, continuation, and re-engagement of PrEP. So that is the approach that the Ministry of Health in South Africa is currently taking to ensure that the modality or the approach is really scaled up. And I think, like Uganda has also said, amongst the adolescents and the youth, and we're also working closely with the Department of Education to make sure that these tests are available in our higher health institutions like our universities, and maybe in the future even go into our schools, high schools, which is a very difficult sector to break into. But I think with the continuation and continue with, advocating for it, I think we will break through and see HIV self kits available in our schools. Thank you.
That would be wonderful to see. Great. Well, I think we're going to open it up to the audience for any questions. So I think we have some roaming microphones. I got the lady in the pink pants, pink trousers to start. I think there was perfect, yeah. Yes, pink trousers and then front in the beautiful dress.
Thank you for the wonderful presentations. I'm Lenka from Eswatini. My quick question will be, are there any experiences or any thoughts regarding using HIV/ST for screening for eligibility? Looking at all the issues that we are having with our paper-based tools, any thoughts around that? Thank you.
Thank you very much for your wonderful presentation. My name is Dr. Alice from Cameroon. So I just want to know for all presenters, some challenges faces when doing self-testing, because we all know SARS is very difficult. They need to do it, go back to their facility for the confirmation test. You said this model helped you to increase the first 97 anyway. So can you share with us some challenges that you face and how did you solve those challenges? Thank you.
Great. Yeah, one more.
Hi everyone, my name is Lamek and I'm from Kenya, and I'm happy that I was involved in the rollout of the self-test program in Kenya. But one of the observations that I had during the implementation was the critical role that the private sector plays when it comes to facilitating access to self-test, especially among the youth. But to the team from Uganda, I'll be very keen to learn from you, how have you managed to really improve on reporting, especially from the pharmacists, considering like some of the private practitioners might not be getting direct support from government, and therefore they don't have an obligation to report to you on a regular basis. But that these are some of the spaces where young people are accessing these kind of services. Thank you.
Great. Karen, would you like to take the first question, and then Alarise, and then Jeffrey?
Yeah, very much love that question. The screening tool. I think you've probably also seen this in the new recommendation from WHO, and I think under STAR, and Eswatini was part of our STAR, we tested these public sector models, facility-based models, I think very much largely rolled out in Zimbabwe and in Zambia. The huge HIV self-testing, we did actually even cost-effectiveness study on this modeling, how introducing the self-testing as a routine screening tool to people who are eligible for testing or should be tested could actually increase uptake of testing services through these different screening tools. So not using their paper-based tools that screens people out, because we might miss actually people. We have demonstrated this by doing this in South Africa, that with these screening tools that people were using at public sector healthcare facilities, we lost actually people. By offering self-testing in outpatients and any entry points that people can come into health delivery system as a screening tool is actually very effective and cost effective, and increases the number of people in coverage of testing at healthcare facilities. So I think that's something that I know that Eswatini is engaging on and is very effective, and especially as people are still accessing testing services at healthcare facilities, self-testing ensures that everybody that needs to be tested gets tested. Yeah.
Alarise?
Okay, thank you for the question. Like I had indicated, through self-testing, it assisted the country to reach its first 95. For an example, when we had a pregnant mom who was HIV positive, we would then offer self-testing for her to go and test her husband or her partners at home. And by doing so, we then reached the population that was not really seeking healthcare within our healthcare facilities. We also had healthcare workers where we had our powers of peer programs, where we had our healthcare workers go into communities, test at taxi ranks, test at taverns where people were not really accessing healthcare facilities. And we also, with the men's clinic, we made men feel that they are in charge of their own health care, where we were giving the HIV self test and just giving them information about what they should do if they're tested either positive or negative. And that encouraged men to come back, because like we always said, as much as we might think that people who screen positive at home would not come back. It's like a woman who screens for has a pregnancy test. When it's positive, she really wants to know, is she really pregnant? And that's what we found, that people who screened at home, when they screen positive, they would want to come back to come and confirm if they're indeed positive. So by us going out into communities and trying to really reach people who are not coming to facilities, that really made sure that we reached the undiagnosed and undertested populations. Thanks.
And Jeffrey, private sector linkage.
Yeah, private sector. Very interesting. So for the private sector, really, one thing we have helped them do is to create awareness, people knowing that the kits are there, and also ensuring that the kits are available and accessible. Of course, accessibility comes with affordability, yeah, because we've seen the prices come down as we introduce more options on the market. So for the private sector, really, it's difficult to get the data from there. So all we look at, the proxy you can look at is probably the sales, okay? The sales are increasing. And also if in the public sector, you're receiving people who say they bought a kit and then tested and they've come for a confirmatory test, then you can easily know that actually your efforts in the private sector are working. So it's basically improving the quality of that service. When I get a kit, am I told the right information? Do I know what to do after buying this kit and after using it? Basically that. So that's what we are doing to support the private sector. We are not bothered about who bought, when, but it's rather about what's coming out of this. Are more people accessing the kits? They have the information. Are they coming for the confirmatory test when they test positive? We can even monitor from our toll-free line, because the calls are, we get a report every month, and we can know the issues that came out of the calls, what people are talking about, where they access the kits, and what problems they are presenting. So there are several ways of monitoring than just picking information about the seller, the buyer, and how old they are and where they live. Yeah.
Thanks so much. I think we have time for one final question.
All right, so thank you very much. My name is Ame Adole. I'm from Nigeria, and I work with the Clean Tea Health Access Initiative. We provided TA to the federal government of Nigeria, and somehow we've been part of the rollout of HIV self-testing in the country. Mine's not a question, is like an advice or maybe a contribution. Like around HIV self-testing, I've heard a lot of people talking about monitoring, but I just want to say we should be careful not to do the same thing we did around the conventional test kits, if not to scare users away. Now, in monitoring HIV test, based on my experience, I believe, based on the implementation we did, we saw a lot of people embrace it. A lot of people want to know their status, but they want to know it privately. It's the post distribution now that is the challenge. So we can monitor that distribution, but what I want to advocate today, because CIF is here and a lot of people are here, we need to invest more. HIV self-test is acceptable by a lot of people, just like how pregnancy tests and others are accepted. However, we need to invest more in another level of sensitization of the users. We are now looking at the total market approach to ensure this is gotten from the private sector, the communities, and everywhere they can access it. And I can bet you, someone can access the test kits. He'll go to his private enclave and get self-tested. If the person is reactive, I bet you not, he's going to call in